A very warm welcome to today's ISNTD Connect. I hope that everyone's doing okay and that you've all had a peaceful Easter break. Unbelievably, it's already been a year of ISNTD Connect with well over 60 sessions. So thank you for joining us in today's session, where we will be focusing on schistosomiasis in Malawi. This session is part of the monthly GSA series, the Global Schistosomiasis Alliance, within ISNTD Connect. I hope you've had a chance to tune in for many of those over the past year. And so today we will be hearing all about the lessons from Malawi for the future of schistosomiasis control, with very important learnings for a OneHealth approach. So it's our absolute greatest pleasure today to welcome our 4 speakers. Some are tuning in from the UK and 3 are tuning in from Malawi. We're not jealous at all. And so to take us through these topics today, it's my greatest pleasure to welcome first and foremost Dr. Lazarus Juziwelo. Hello, Lazarus.
Hello.
Hi. Lazarus, probably many of you will know you. You don't need an introduction, but for those who are new to the field, you are a National Program Manager for Schistosomiasis and Soil-Transmitted Helminths with the Ministry of Health of Malawi, and you will be giving us a review of current activities at the national level in terms of the National Control Program against schistosomiasis. So we look forward to hearing all about that. Honing into schisto control at more of a community level, we'll then hear from Dr. Janelisa Musaya. Janelisa, a very warm welcome to you. Hi, nice to have you here with us today. Janelisa, you are with the Malawi Liverpool Wellcome Trust Clinic Research Program, and you're also Associate Professor at the University of Malawi, and you will be telling us about the factors influencing the uptake of preventive chemotherapy in targeted communities. And building on from that, we will then hear from Dr. Seke Kayuni. Hi, Seke, welcome. Seke has, of course, on cue, left the room due to a connection problem, but he'll be back within seconds. Here we go, Seke is back. And in the meantime, I will just introduce Seke, who will be representing the Medical Aid Society of Malawi and also the Liverpool School of Tropical Medicine. Seke, you will be telling us a bit more about communities and giving us an update on male genital schistosomiasis in fishermen on the Lake Malawi shoreline. Seke, very warm welcome.
Thank you, glad to be here.
Hi, we're very happy to have you with us today as well. And tying all those topics together, it's a great pleasure as well to welcome Professor Russell Stothard. Hi, Russell.
Hello.
Hi. For those who perhaps are quite new to the field of schisto, you are Professor of Medical Parasitology at the Liverpool School of Tropical Medicine, and you'll be rounding up all of these presentations by highlighting the impact of recent ecological and biological changes in Lake Malawi, and importantly, what this means in terms of its interplay with future control, and also highlighting that very crucial need for OneHealth approaches to disease control. So a really fascinating session ahead of us. Without any further delay, I am going to hand over to you, Lazarus. I'll start your slides off, and we look forward to hearing all about the National Control Program in Malawi.
A warm welcome to you all this afternoon and to others in the morning to Schistosomiasis and Stage Control Program. That is the country profile for Malawi. I just wanted to show you how the schistosomiasis is spread. In fact, it's affected by the stool and urine with infected eggs into the waters, and from there it spreads after the fecally enters into the skin up to the body, and it affects the whole parts of the body through the urogenital tract and also intestinal tract. So based on that, it creates a lot of effects, which includes the major challenges of the body, and that is due to the migration of the worm, the schistosoma in the body. And this has been affecting a number of people in the whole world. At above 221 million people are affected. Unfortunately, Africa is highly affected, and that is the challenge. And the most affected are the women, children, manual workers, and fishermen. And this is affecting most of our rural community, which is mostly the majority of Malawians. And that is also affecting the female genital schistosomiasis, which is a major risk factor for HIV infection. And that is why there are a number of preventive measures and control measures, which include preventive chemotherapy, snail control, environmental management, health education, and also in terms of WASH, which includes the access to safe water, which prevents somebody to be in contact with water. So that is the major challenge with African situation, where a number of people who are affected, especially in Malawi, almost 20% of the population lives along the water bodies. And unfortunately, more than 80% of the 18 million people in Malawi lives along the poor or rural communities, which are highly susceptible. In Malawi, the most dominant species are Haematobium and Mansoni, which is different from other areas like in China and other areas. And you know, our population is having majority of young ones, and the 5 to 14 years population is highly susceptible, and those are the young ones and the young adults and the children who like to swim in the water, and sometimes people who are fishing, and those who are working in the education schemes and rice schemes. Those are highly susceptible people. Potential sites include areas with high waters, and Malawi is privileged to have game reserves, and also some national parks, and also good waters where tourists can go around, and also domestic activities which take place along the water bodies. All this, when we are affected with the schistosomiasis, it reduces the GDP for the country, and it affects our economy, because people are very much afraid of being affected with the schistosomiasis, and that's very common in so many areas in the country. Unfortunately, the sanitary coverages are somehow very low in most of the areas, and with recent floods, we have been highly affected because the WASH coverages are totally reducing. We have been having an initiative of open defecation free initiative, which is trying to encourage people to use latrines. Unfortunately, the floods has been reducing those sanitary shelters. Recently, we are having a new, I can call it a new crop of people who are car wash people within the urban areas. Those are also highly affected population. Historically, we've been having a number of activities in the country, and in the past, Malawi had been having other interventions, which was including treat and test and treat, and normally in other areas it was localized PCTs, and all those issues were happening, but it showed that the prevalence rate was not going down. Minister of Health tried to conduct the baseline mapping in the previous years in around 13 districts, which was in 2003 and 2010. But those early studies, normally they were using urine filtration and also cattle cuts. And it was indicated that the dominant, the schistosomiasis, Haematobium, and also the Mansoni, which are common in the country. And that has been observed that after we had a support from SCI Foundation in 2011 and 2012 onwards, we had now to try to work to the whole country, and we had to conduct further analysis to other districts, and the other 15 districts were mapped, and that was using the STI, which had developed a protocol for that in conjunction with the WHO conditions. And in 2015, we had to also conduct a special study in Likoma Island. It's an island within Lake Malawi. That was in 2015, and it was indicated that the prevalence was so low, less than 1%. So that was how we were working. And if you can check on the map, you see the first map is indicating the general, you can say NSCI, which not SCI, but any schisto, which we can see that we had a number of areas with high prevalence. And the other map, the one at the center is that one for Haematobium, and the other one is for Masonite. That was the indicator for baseline surveys. And if you can see, the country had so many areas with high prevalence, but you see that after that, we conducted a number of activities, including preventive chemotherapy. And if you see the table, you see the districts with the prevalence at baseline and also prevalence at after the assessment. So it has indicated the one with yellow indicates that those are moderate districts, and the other one without color and with extra blue or something like that is those ones which are low. So that is how we have managed to reduce the prevalence. And based on that one, hello. So this slide is indicating now the areas. Now, like those circles are indicating the schools where we corrected the specimen, and the ones with red ones are those with above 5%, which are still under morbidity control, and those with blank circles are those with less than 1%, and those with the orange are those which are between 1 and 5%. So you can see that Malawi has achieved a lot in terms of working on the control of the schistosomiasis. And looking at that, you see that Haematobium is more predominant compared to the Masonite, to the first map, and the second map is the one with Haematobium. And that one is also just indicating the districts. Unfortunately, it requires somebody with good eyes, but those are indicating the prevalence in districts. Based on that, the 80 districts are low prevalence, and also the 10 districts are those with moderate. That is total 28 districts, but that one I missed to indicate the Likoma Island, which is of no risk, which is the total to 29 districts. I think I repeated that slide, sorry for that. We had some challenges for COVID-19, and primary schools were closed last year because we normally use school-based, and many other activities were stored. And concerned with the expiry of preventive chemotherapy, plus Quantel, we had to conduct the MDA within the COVID-19 situation. So we thought of having about three districts, which we had an experiment, and after that we scaled up to all the districts, and for that we had to process PPEs, and normally the staff, which we have a certain cadre, we call health surveillance assistants, who are community-based health workers, and those are the ones which were going around to treat the people which are closer to the community. and it was observed that we had good participation. And that one is just trying to show you the figures which have been treated in 2018, 2017, 2018, and 2019. We haven't finalized the 2020 MDA data, and I just indicated those absolute figures for that. That one is just trying to show you some of the reasons why we were failing to treat some others. And if you see, you have got a number of issues which are indicated here, there, and you can see that others were having some other excuses, but all in all, majority received the treatment. We have got challenges for our setting for us to reach elimination levels. We are still having research gaps for some indicators. When you look at like factors leading to maybe some low prevalence in some districts, sometimes we are supposed to not only to say that we are appreciating that it's low, but we need to have a special research and have learning and sometimes try to find out lessons learned from those areas. And also we have got a challenge of vector control. We don't have any activity happening now on vector control, and also inadequate linkage with WASH. At the meantime, we are trying to work on that, and we are working on the WASH NTD strategy, which we have contracted a consultant with support from our SEN project. And also inadequate linkages with the other departments within Ministry of Health, that is HIV reproductive health services on genital schistosomiasis, which has been our dream to do something on that, because that is affecting most of the women and also men. Inadequate support by private sector. In other words, when we are visiting some areas, we have discovered that we need to include the private sector, who can even provide some support within the process. And also low level of knowledge of the disease. In some areas, we find that even those learned, they don't have enough knowledge on schistosomiasis. So we need more noise about schistosomiasis. Inactive system strengthening, that is to say, most of the donors, they just support in preventive chemotherapy and other intervention. But in terms of routine treatment, think about surveillance for complications like ascites and other NCDs like the bladder cancers. We need to work, strengthen those surveillance and even try to use that as a learning tools. And that is what we have observed, that we need to gain more support. We are still having some plans to do, in terms of mapping, we are planning to change our approach from morbidity control to elimination. And for us to do that, we are shrinking our PCT to lower implementation unit. And we thought if we can have precision mapping for some IUs which were not mapped, I think that can help us, especially in the lower implementation units. In terms of diagnosis, we think if we can emphasize on routine diagnosis, that is for those patients who are coming at the facility. So we need to think of that, and also looking at the transition from these filtration and also catheters to more sensitive tools, which can help even to detect the disease at early stage. And also we are trying to emphasize on the surveillance system, also case management, and also behavior change communication. Thank you very much for your time to listen to my presentation. Thank you.
A very big thank you from us, Lazarus, for this very informative overview, and particularly befitting today on World Health Day 2021, which the World Health Organization themselves have used to launch a campaign to build a fairer and healthier world. and in their own words, really framing this in terms of vulnerable communities, and also addressing these inequalities that are often preventable. So a really great example here of work being done in Malawi to tackle precisely that. So thank you very much. I think I'll hand over now to Janelisa. Janelisa, I'll just stop Lazarus's slides, and whenever you're ready to share your screen, please.
Thank you so much.
And Janelisa, you will be taking us through some of your work and some of your observations about the factors that have influenced, both in a positive and a negative way, the uptake of preventative chemotherapy.
Thank you very much. So I'll just continue from where Dr. Lazarus Juziwelo left. So from the control program where Dr. Juziwelo is heading, the goal of Schisto program of control is actually to reduce burden of schistosomiasis and soil-transmitted helminth to a level of no public health importance. And the target is by 2025. So one of the main strategic objectives to achieve that goal is actually to do mass drug administration. And the target is to achieve at least 75% of therapeutic coverage among school-age children, and the same target of 75% to among communities. The reassessment mapping that Dr. Juziwelo talked about in 2017 to 2019 in the 18 districts he describes shows that there are low prevalence rates between 1 to 10% in some districts, in about 10 districts, and also there is some moderate infection between 10 to 50%, and one district with less than 1%. So when we look at the prevalence that we have and the target that we are looking at, we then come to think about how can we improve or how can we do better to have an uptake of the drugs that we offer. So the first thing to look at it is what are the barriers actually that are causing us not to reach or not to eliminate a schisto to a level of no public health importance. So I was looking at a number of factors, and actually we found out that the main barriers actually are twofold. There are those that are community-based, and there are those that are also institutional-based. If we look at community-based, the main thing that is affecting people to uptake praziquantel, for example, is one, the rumors that are going around. There's rumors that when you take praziquantel, the drugs are meant for depopulation, therefore you'll not be able to have children, so people are afraid to take the drug. Rumors of issues to do with side effects of the drug, who might get weak if you don't eat, maybe there'll be a lot of complications that will make other people fail to take the drug. Superstitions, beliefs. There are people that believe that you don't have to take drug, and there are superstitions about taking this disease that are affecting the uptake of chemotherapy. And the major thing really is understanding of the disease itself. Dr. Juziwelo has talked about having about people that are already knowledgeable, but they have low levels of understanding the disease. So if people are failing to understand the spread, how do you get this, how do you get in contact, how can you prevent it, that understanding fails, then there's a problem with people. Actually, there are things that go around talk about. We've been we've been drawing water from this land for so many times, for so many years, and why should we stop now? Unless people understand, then we have issues. And another thing is about access to drug. The distance between where people are, the communities, to where the health center is, normally some are above 10 kilometers, other 5 kilometers, and it's difficult to go there. And if a child is just passing out urine, blood in urine, it's not something that a parent would really worry much to go to the hospital. So you find that the access to the drugs is also in itself a barrier to the uptake of chemotherapy. The other hand is about institutional. The issue about sensitization that targets, and maybe before I go to institutional, I think the big major problem that we have is about COVID. The issue with COVID, when people come to villages, especially in areas that there's these rumors about COVID vaccine killing people, having blood clots, people are really afraid. If you have a 4x4 coming to villages, bringing drugs, people will just run. So that's a big, currently it's a big issue to do with chemotherapy uptake. When it comes to institutional, talking about sensitization, we need the sensitization that targets behavior change. We can have sensitization for the sake of awareness, but if it does not target behavior change, then we still have issues in terms of controlling schisto and chemotherapy uptake. Drug procurement, there's the issue of donors getting funds to procure drugs. And if we don't have drugs on the ground, we have issues. Distribution process, especially the delivery platform, who is delivering this drug? Do people have confidence if we are doing mass drug administration? Do people have confidence? So based on that, actually, we have a project that is running, which is called SCIMDA CDI project. This is the Schistosomiasis mass drug administration community directed intervention project that is running in 3 districts in Malawi, which is Mangochi, Zomba, and Chilazulu. The CDI approach actually is good because it's an intervention that is undertaken at the community level and is actually directed by the community itself. In 2018, the MGA coverage in Malawi was actually high for praziquantel, around 87%, and 82% for albendazole. This was done by using the health surveillance assistants. These are attached to the hospitals, and they are used to do a number of health-related activities. Now we want to see if we can actually target the community itself. Can we raise the bar? Can we raise it to 99%, for example, for praziquantel? So community interventions is using community volunteers or agents who are actually selected by their own communities to perform basic health and education duties. So the research question for the SCIMDA project is actually to check whether CDI approach can be effectively used to deliver MDA to control NTDs, with the main aim that the communities will actually own this. So we want to improve this approach by the community owning the MDA approach. So probably the number of people that can be targeted or that can receive the drug will increase. So our project is divided into 2 arms. We have a control group and an intervention. The control group is basically what the Ministry of Health or the government is actually doing right now, using the health surveillance assistance to distribute the drug and using the whole same system that the government does. So we use that as a control group. Then we have an intervention where we have introduced the CDI approach, where we are using the community to select their own volunteers who will then be used to distribute the drugs for schistosomiasis. And so in each district, the 3 districts, we have health centers, and in these health centers, these are where we go and visit the villages. So to do that, actually, we started with conducting trainings. So we conduct trainings to the people that we will, because what we have done with the CDI is to make this use the system so that when the project is over, it's sustainable. So we use the Ministry of Health system. We use the district health systems offices. So we train those personnel, and those personnel will go into the communities, into the health centers, and train them on how to use the CDI. And part of the project also is to try to analyze and come with answers whether this CDI is better than the HSA approach. So what you have here on my slide is us training the enumerators, going to the field to try to find out whether the CDI approach is actually working. So we had done the first MDA and the second MDA. Now we are going to the villages to try to find out whether the approach was working. And you can see we are using the one-on-one interviews. You can also see that we are using the focus group discussions to achieve this. Now, I'm coming back to the barriers. So we looked at the barriers. We are trying to use the CDA approach, and we are currently trying to analyze that data. We might present it at a later stage. And then we want to see what other things can we also add to enhance the uptake. So still looking in the two arms, looking at the community, we need to involve parents. Once parents are involved, they understand, then they will be able to help, especially in children, to take these drugs easily. At the same time, the parents will accept, they will receive this approach, and they will also be able to help others actually to take this drug. So one of the things is making sure we involve the parents. Secondly, we need to align distribution of our drugs with the harvest season, because of that notion that when someone is hungry, then it is difficult for them to take the drugs. We have what we call a college-based, school-based program where the children are given college. And whenever the drugs are aligned with that, there's high uptake of the drugs in schools where the porridge are given. But in schools where these are not given, you see some children running away from actually getting these drugs. So for community-based, we need to align to the times where there's bumper harvest, where the people have food, that when we come and give them the food, the idea of that I'll be weak, I'll die, and all those things will probably be reduced. So on top of this is the issue of awareness. We need awareness that is locally led, community-based awareness system. So training the community volunteers to sensitize the communities. Because if the person is their own, the communities easily accept the message that they involved. At institutional level is at least involving developmental partners, especially when we have issues of funding. So we need to develop, to involve developmental partners, and also effective coordination among stakeholders. Dr. Juziwelo was talking about issues about WASH, HIV reproductive health system, and the ministry. If we can work together at institutional level to align our activities together. So we have issues of transportation. If there's one activity going on, the other one can jump on the same and be able to go and give out MDA. So that's aligning MDA with other activities and coordinating with stakeholders, and also timely planning and delivering of drugs. Because when the drugs are delayed and they reach rainy season, we have issues with the road. You find that the drugs are just at the hospital, probably expiring, and the uptake will be reduced at that point. So this is just some of the issues that we can actually do to enhance the uptake of drugs in our community. That ends my presentation. I would like to acknowledge the SHIMDA team. Thank you very much.
Thank you so much, Janelisa. That was really informative, and also perhaps one very small silver lining of the COVID pandemic is that it has enhanced and forced those conversations about infodemics and fake news and so forth. So really interesting to hear your very concrete solutions and approaches to making sure MDA reaches those who need it the most. We'll come back to that in a bit. Our presenters are getting lots of thank yous in the chat for your wonderful insights, and for any of the attendees who haven't yet been on the chat, please don't hesitate to go over and post any of your comments or your questions, and we'll come back to those in a bit. But right now I'd like to hand over to Dr. Seke to give us a bit more insight into specifically male genital schistosomiasis among fishermen. Over to you, Seke.
Hello. Thank you. I will briefly go through one of the chronic complications of schistosomiasis. And as Lazarus said earlier on, schistosomiasis sometimes you usually get some chronic complications which affect the genital system of both males and females. For females, there has been extensive work which has been done, reporting of some of the presentation of female genital schistosomiasis, and particular diagnostic tools have been developed in order to make an appropriate diagnosis of female genital schistosomiasis. However, for FGS, I think still in endemic areas, it still gets mistaken for a sexually transmitted infection, just as male genital schistosomiasis is also mistaken as a sexually transmitted infection like gonorrhea. So if you can look at the picture here, basically someone with schistosomiasis involving the penis. And basically this would arise from eggs, schistosoma eggs, or the abnormalities arising from the eggs staying in the genital organs or genital system of men. And this is this is quite common in endemic areas or in people who are visiting areas where schistosomiasis is quite prevalent. And some of the presentation, usually you would have people having pain, pelvic pain or lower abdominal pains. They would have blood in their seminal fluid. Sometimes their ejaculates are altered, and others would present with cases of infertility, which would result from schistosomiasis. So part of my PhD, which I completed last year, was to study how much schistosomiasis resulting from genital complications, male genital schistosomiasis, is amongst fishermen along Lake Malawi. And prior to that, I did a systematic review where I had to look at how much, what is the burden of male genital schistosomiasis. And indeed, we noted that there is a substantial burden of genital schistosomiasis involving males in endemic areas, more especially in Africa. And it was either through reports coming from reports of people who presented in health facilities from the endemic areas in Africa, or also from visitors. For example, people coming from Europe, especially, for example, from the UK, visiting Africa, France, visiting in Sub-Saharan Africa, as well as I think in South America. So genital schistosomiasis is as common as urinary schistosomiasis, though it is underreported, and that's why we described male genital schistosomiasis as an ignored complication of a neglected tropical disease, which is schistosomiasis. So starting from 2017, he carried out a longitudinal cohort study amongst fishermen along southern part of Lake Malawi, especially in Mangochi district. Mangochi district is one of the popular districts in Malawi because it's known for its tourist attraction facilities in these areas. So we looked at the fishermen to see indeed how much is the prevalence of male genital schistosomiasis. Apart from that, to understand the knowledge, attitude, and practices around male genital schistosomiasis, to see whether we can pick any genital abnormalities which would be associated with male genital schistosomiasis, as well as to see if at all people who present with genital schistosomiasis, MGS, would be able to be treated using the mainstay treatment for schistosomiasis, which is plasquantine, and to see if at all those who have early changes or early abnormalities would be able to resolve their abnormalities. And also part of it, we did more or less like a prospective pilot study to look at whether indeed there is indeed a connection between genital schistosomiasis and HIV, and to look at whether indeed male genital schistosomiasis increase the viral shedding of HIV in seminal fluid of men. So in the In the communities along the lake, we recruited fishermen who we ran questionnaires, as well as asked them to give us urine for parasitological investigations like urine filtrations, as well as point of care CCA test, which is able to detect intestinal Schistosoma mansoni, as well as to we asked people to give us some blood, which we did some ELISA serology. And also for those who had HIV, we did HIV viral load from blood, as well as we asked them to give us semen, which we looked directly under a microscope to see at all whether we could be able to identify eggs, as well as we did a more or less a microscope after centrifuge to see in the sediments whether they have eggs or not. And we did also a real-time PCR on the semen sediments to see whether at all they had schistosoma DNA to detect male genital schistosomiasis. Apart from that, we did ultrasonography to look if we could identify some genital abnormalities in their prostates, seminal vesicles, as well as in their testes, and also the urinary bladder as well, to see if there is any urological pathology. So at baseline, at the start of the study, so we recruited about 376 people who were aged between 18 to 70, and most of them had stayed along the lake in this endemic area for over a year or so. And about 210 people gave us urine, of which 17% had eggs, Haematobium eggs in their urine. And we had the eggs ranging up to about 186 eggs per 10 mils of urine. So we had about 3 people who had heavy infestation of schistosomiasis. And in the semen, we were able to detect about 12 men out of 114 men who gave us semen. Those of it, about 10% had schistosoma Haematobium eggs in their semen. And of note is we didn't see or we didn't detect anyone who had mansoni or intestinal schistosomiasis or eggs related to intestinal schistosomiasis in semen, which has been previously reported, but in our study we didn't see anyone who had mansoni in their semen. And when we did a real-time PCR, the prevalence went up to about 26.5% at baseline, which gave us an understanding that only looking at eggs does not exclude someone of having genital schistosomiasis. So thinking that about a quarter of all men or the fishermen who were in our cohort had genital schistosomiasis of some sort. So basically, this one is giving us a picture of Haematobium eggs looked with under iodine on a filter, and this one looking directly into the semen. That's what the egg, we were able to detect the eggs. And of note, we noted that some of them, those who were positive on real-time PCR, a good number of them, about 7, didn't have eggs at all in their semen or in their urine, and 6 had eggs in the urine, which was quite fascinating to find to see these findings. And certainly this gives us a picture of the symptomatology. We had about people who, about a third of them reporting that they had dysuria. And on the symptoms related to genital schistosomiasis, we had very few people reporting on having symptoms. And interestingly, those who had symptoms, none of them had eggs or was positive for real-time PCR. So meaning that people who would have genital schistosomiasis, they may not present symptoms at all, or they might ignore some of the symptoms which they are presenting as well. And also of interest was looking at asking them about their spouse. Some of them presented that their spouse had symptoms related to female genital schistosomiasis, which although being very minimal, but gives a picture to say that yes, I think in areas where there is male genital schistosomiasis is prevalent, female genital schistosomiasis will be alongside as well. So these would happen more or less concurrently, and that it maybe triggers an idea of doing both male and female genital schistosomiasis investigation in these regions. And in addition, what was very striking was that despite Quantel being available or being given out, just as Lazarus and Janelisa have said, as through mass drug administration, the fishermen, only about a third of the fishermen accessed Quantel during mass drug administration at all, which was quite interesting. And basically, it was, some of them reported that because most of the times are working doing fishing as well. So as such, they would be not around during the time of mass drug administration, as well as maybe the health-seeking behavior of men, which usually is associated of low uptake, as such that most of them wouldn't go to the health facility if they are not very, very critically ill. And then following up over the months, because we followed up the men over the period of 12 months, repeating the investigations again, we noted that after 1 month of giving them Quantel, we had none who had eggs in their semen after 1 month follow-up. And the urinary, for the urinary schistosomiasis, it went down from 10% to about 11%, but still the real-time PCR still remained high, meaning that despite that they didn't have eggs in their semen, still they still had a picture or a signature of genital schistosomiasis in their semen. And of note was that I think after following them at 3 months follow-up, we noted that the prevalences went up from 0% of having eggs in urine to back to 10%, and the real-time PCR went up, as well as the urinary schistosomiasis went up. So meaning that there was more or less reinfection happening, which indeed makes sense because these the men were going back to the same water sources despite the continued health education as well as other interventions which are put in place. At 6 months, we saw a reduction of the prevalence, both in urine, in semen or eggs, as well as in real-time PCR. And at 12 months, there was more or less a mixed bag whereby the infection, it went up again. So meaning that because people are still exposed to the same water bodies, then the infection continue happens, which gives a need to say that I think continuous health education as well as readily available treatment would be able to go a long way in reducing this kind of the prevalence for male genital schistosomiasis. And when we looked at the when we looked at the ultrasonography, we had about 7% of the men who had genital abnormalities on ultrasonography, and of note, we had one who was more or less a classical male genital schistosomiasis picture, because he had a nodule in his testis, and his seminal microscope as well as real-time PCR were positive. So meaning that someone with genital schistosomiasis do present with as well as genital abnormalities, which you are able to detect on ultrasonography. And just to highlight that the ultrasonography which we did at during this this study, we did transabdominal as well as scrotal ultrasonography. Ideally, what is usually recommended is the endorectal and the endoanal ultrasonography, which is usually not available, and it was not available during the field work as well. But the transabdominal would come closer to be able to pick up some of the abnormalities which you are able to see. So genital schistosomiasis, which goes untreated, would give abnormalities like nodules in the testes, basically as a result from calcification, issues of hydrocele, you can have hydrocele, as well as enlarged abnormal seminal vesicles, as well as with some calcifications of the walls as well. And on the HIV seminal viral load, it was interesting that we had about 33 participants who we had recruited in this small study, or followed up over a period of 12 months. And we noted that those who had genital schistosomiasis were able to detect their viral load at baseline, with about 4 of them having a detectable viral loads of over 40 cells per mil of their blood, as well as of their seminal fluid. And of this, we noted that after giving them praziquantel, most of them, their viral load became undetectable. For those who didn't have genital schistosomiasis, a few of them had detectable viral load, which eventually declined as well over the period under study. And this is quite interesting. Although these were very small numbers, it was able to show that people who have schistosomiasis may have higher viral load shedding as well. Of interest is that we didn't do any other investigations, which would say that there might be other confounding factors. However, from the history as well as for the investigation, we are not able to find other key problems like genital herpes, like TB, and also other confounding conditions, which would explain the detectable viral load. So in a way, I think there is need to do a lot more investigations to look at schistosomiasis and HIV to see if at all giving praziquantel would contribute towards reduction of HIV incidences as well as prevalence, and through people more or less transmitting HIV more for those who have both HIV and schistosomiasis. So in summary, genital schistosomiasis affecting males is quite prevalent in endemic areas. In our case, we found that fishermen, about 10% of them had genital schistosomiasis, and this prevalence goes up to about 25% if you do molecular sensitive tests like real-time PCR and real-time PCR on semen. And the HIV has a potential of affecting the viral load shedding, so it can increase the viral load shedding both in blood as well as in semen. And praziquantel is good at clearing eggs. So if you have acute kind of infection where you're excreting eggs in your semen, it is able to clear that egg reduction. So it will be able to kill the worms which are around the genital organs, and it can also contribute towards reduction of viral load. It can contribute towards viral load, and integrated control interventions for schistosomiasis could also help in controlling HIV infection, as well as controlling the chronic morbidity resulting from schistosomiasis. So we are very grateful for the participants who took into this study. It was not an easy one. We had to do a lot of convincing. You can see the men trying to talk with them, convincing them to do the study itself. All over, we had children following us who also took part in the other studies, which we are very, very grateful about the local leaders, the health team in Mangochi, the National Control Program, Lazarus, and the team, and also the team from Liverpool, from Holland, from Leiden, as well as from Tilburg, those who did some molecular tests, as well as other, like in Liverpool, University of Liverpool, those who help us in doing the viral load analysis. in order to make sure that at least we're able to come up with substantial results, which will be helpful in the control of schistosomiasis, both for male genital schistosomiasis and female genital schistosomiasis. And just to say that currently we are working in the lower part of Malawi, in the district of Sanje and Chikwawa, where we are looking at the morbidity associated with female genital schistosomiasis. And there are indeed interesting findings which we are seeing from the women who are taking part in the studies, to say that yes, there is indeed genital schistosomiasis affecting women, and indeed there is need for a lot more health education, a lot of more treatment being provided to be available in this area, so that at least people benefit and we're able to kill the worms which are in their body, and also to look in the long term to say that what else can we do on the environmental control, look at the seminal control and see how best we can achieve that. So thank you so much for listening to this presentation. Thank you.
A very big thank you from us all, Seke, for this hugely comprehensive presentation on a really, really delicate and complex problem. So thank you very much. Really the most neglected sexual and reproductive health challenge in sub-Saharan Africa as well. So lots of questions have come up in the chat regarding this. But before we move on to this, I'll hand over to Professor Russell Stothard to wrap up our presentations and discussions.
Thanks very much, Marianne. So good afternoon. I'll give a quick whistle stop of what this last part of the talk is, but I want to remind you that schistosomiasis in Malawi is quite an old problem. But 40 years ago, it really wasn't a problem in the lake itself, in Lake Malawi. It first started to hit onto international radar in the mid-80s as we saw people who were tourists traveling back to the UK, the USA, with complications of Haematobium infections. And it was argued for a long period of time that they didn't catch those infections within the lake, it was around the periphery. So that kick-started a little bit of environmental surveillance around the perimeter of the lake. And we can see that blindness globosus was found in those lake margins. But what was particularly interesting is it kick-started greater scrutiny in Mangochi region on Cape Maclear, and the Danish Bilharzius laboratory group, of which Janelisa was involved in the late 1990s, actually showed there was a new type of schistosomiasis transmission going on involving a deep water snail, Blindness niasanus. And that really made the transmission picture in the lake very different. This snail was found in deep water on sandy beaches where you have tourist hotels, and it was pretty clear that transmission was taking place. Now, 10 years later, as you saw from Seke and Lazarus, there's been activities going on within the lake and also with regard to schistosomiasis control. But I just want to remind you that in the lake, there's been extensive overfishing throughout that period, which has been changing the ecology of a lot of the snail hosts in those locations. And just to kind of show you where we're going at the moment, we've been able to show that there's been changes in the lake, the snail lake fauna. In particular, we've found Biomphalaria pfeifferi, which has actually kickstarted a novel foci of intestinal schistosomiasis. But what's even more important, and we look at the epidemiology of schistosomiasis combined, we're finding schistosoma Haematobium hybrids, which are linking up with veterinary schistosome, Schistosoma bovis, Schistosoma mattii, and also finding a new Bolinus fauna within the lake. So this is all mashed up with intestinal and urogenital schistosomiasis with a complicated set of snail actors as well as parasites of different genotypes. So we'll delve into that a little bit more detail. Just to remind you that there's been an active control program with the help of support from colleagues from SCI for well over a decade. And then, as Seke mentioned, we're interested in finding out what the pathology was with regard to Haematobium in men, with regard to male genital schistosomiasis. So just to draw your attention on the top of the panel here, a lot of water contact along the lake shore. And to understand reinfection patterns, we were conducting snail surveys at the same time as Seke was doing the studies in the adult men. Just want to point out there's also probably a preschool age child problem of schistosomiasis, which is a little bit overlooked. This is just advancing, unfortunately, by random. But when we're doing those snail surveys for Bolinus, we really were surprised to find biofilariae, as you see under that red arrow. Along that shoreline, there are pockets of transmission, or at least pockets of snail colonization, which are giving rise to opportunities of intestinal schistosomiasis transmission in the lake, as well as in some of the peripheries. So that's another ecological environmental change which is going on in the lake, which we should be mindful of. And just to show you, on the right-hand side, there's a fishing boat, of course, that's landed in a fairly swampy region of the lake. That happened to be a very productive biofilariae habitat, and we've been monitoring that location for the past 2.5 years, and they're always finding live biofilariae in that location. So those snails are in the lake to stay. So we reported that unusual occurrence of biofilariae within the lake. We've done various snail surveys in greater detail along that part of the shoreline of Mangochi, which is over and above what the National Control Programme can do, because we're looking at a very fine scale granularity of about 50 kilometres of shoreline. But we reported it, and on the left-hand side, we can see in those white circles areas or locations where we found biofilariae, in addition to Bolinus, for example. And just pointing out that when we're looking at the ecology of the lake, we've been taking parameters such as pH and conductivity, and we're noticing changes from year on year. And it's just to point out that even though it's a large lake, you do get seasonal patterns as well as phenological patterns. So there are probably changes within decades, as we saw at the start of the presentation. Now, most importantly, we followed up in 3 schools quite close to those biofilariae sites using a combination of standard parasitology and cat-to-cat sampling. And we're able to show that up to 50% of the children in some of those primary schools had intestinal schistosomiasis. We also tracked some of those children to lake shoreline sites to prove they had water contact. And the children at Samama School, for example, were in close proximity to a location where you're consistently finding biofilariae. We've made a collection of all those snails to try and find out where's this biofilariae actually come from. And it's really rather pleasing. Student Mohammed El Habi has been sequencing all the snails that we've collected. There's only about 100 or so. We found 5 different mitochondrial haplotypes, but 2 of those mitochondrial haplotypes are identical to biofilariae pfeifferi found in Zimbabwe, some 350 kilometers away. So it's likely that there's a population, a larger population of biofilariae across that zone of Zimbabwe, Mozambique, and Malawi. But it's invading into the lake. It's low diversity as well, so it's probably been a recent invasion. We've looked at microsatellite loci and shown that there isn't much variation in genetics for any of those snail populations within the lake, very low heterozygosity as well. We've also typed those snails for schistosome DNA, finding about 40% of the snails infected, or at least having the presence of schistosome DNA inside them. So it's indicative that there's within autochthonous transmission of intestinal schistosomiasis in this part of Lake Malawi. And it raises the question, of course, what we can find on the margins of the lake or in the near shoreline, but it's likely in that part of Mangochi, there are deep water reed beds, which are some 10 to 15 meters in depth, and I think we believe there are populations of biofilariae quite deeply embedded in that lake, and they're perhaps spreading as the lake itself is starting to sediment up in that part of the corner. Now, interestingly, we've expanded on those 3 observations in the schools and surveyed 12 schools in total around that U-shaped part of Mangochi, and we found that the prevalence by urine dipsticks is about 31%. Noticeably that we can find children also excreting Schistosoma mantsoni eggs. Interestingly, their cat-to-cat intensities are quite light. And what's particularly intriguing in my mind is even though they have light egg excretion in their fecal, you can often find children which have got ectopic mantsoni excretion in their urine. As Seke was saying, we haven't found Schistosoma mantsoni eggs in semen, but we can certainly find them in urine, in addition to mixed infections with traditional Haematobium. So that's indicative that there are probably cross-specific worm pairings taking place in those children which happen to have a co-infection of intestinal schistosomiasis on top of their urogenital schistosomiasis. We also had some surprises when we looked at the urine in children in those surveys. We saw some very unusual eggs. So those of you who know about egg morphology, this particular egg on the right-hand side is not a Haematobium. It's in the Haematobium group. It could be Schistosoma leipuri, but we haven't been able to genotype that yet. But we have actually also seen other egg morphologies which cross-talk with Schistosoma margreboii. That's another schistosome parasite found in livestock or either wildlife locally. It then really alerted us to the fact that because of these cross-specific worm pairings going on within children, there are new mating opportunities. And also along the shoreline, we found a new fauna of Bolinus. We're finding Bolinus africanus in addition to globosus, as well as another snail, Angolensis, and also a snail which we haven't been able to fully identify because it's new. Anyway, all of that combined, those new snails, those parasites, brings together a changing epidemiology of schistosomiasis on the lake. So I use this term hugs because if you remember, male and female worms form this pair, and the male actually hugs the female schistosome and tries to mate with it. Of course, if that mating is successful, it might give rise to either an intergressed or a hybridized species. So just imagine how those changed phenotypes and changed genotypes of worms interact with the snails and the transmission cycles, and also how these hybrids could be spreading, across the lake. What we do know, and we wrote an article to kind of have a little bit of conjecture to this, was in Mangochi, we're finding a Mattii Haematobium hybrid, which is Mattii by mitochondrial loci and also intergressed at nuclear loci. But further down the Shiri River, down towards Nasanji, we were finding the Schistosoma bovis Haematobium hybrid in that the bovis mitochondrial signature was there, but it looked like Haematobium binuclear. What's particularly interesting about that particular hybrid is you find that on Corsica. So that is spread out from West Africa. Colleagues at the Naturalist Museum and in France have done a lot of work on that. But that hybrid, that's the first time I think it's been found south of the equator. So not only has it gone north, it's also gone south, and it might be utilizing different snail hosts. So just to remind us again, we've got a complicated picture of transmission now in this part of Lake Malawi. We have implications of livestock schistosomes, bovis being one, Mattii another, perhaps margreboii as well as leipuri, circulating in either cattle, sheep or goats or either wild primates or rodents in that shoreline, interacting with the snail fauna, and then interacting, of course, with people that make use of that water from preschool age children all the way up to adults. In addition, those people who are infected with Schistosoma mantsoni might be allowing some new intergress forms to be formed, in the sense that the mantsoni might be mating with a hybrid of a hybrid or something like that. So we have to be very alert to the new changes in the epidemiology of intestinal schistosomiasis. I think 5 or 6 years ago, we probably didn't believe that would be possible, but colleagues again in France have actually detected integration signatures between Haematobium and mantsoni. So I really wonder if this is an evolving situation whereby new hybrids are starting to cross-talk with mantsoni and giving rise to new combinates. So we have to think of all the type of hybrids. We're very fortunate to have a project starting in the next couple of months in Malawi with Janelisa to look at the importance of Haematobium hybrids. And that raises some interesting questions about the diagnostics, the clinical significance of these hybrids in people. And I just want to point out, to kind of really fully understand that mating biology is very arduous. We can't really do this in the lab anymore. It would take 2 to 3 years to kind of cross and to do a mantsoni cross with a Haematobium hybrid. We'd have to kind of know which snails we want to passage them through. We'd have to get male and female Seke, carefully infect an animal, get those progeny back out, genotype them. It's a lot of work, so I'm afraid that's probably not going to happen. But what we will be doing is looking at greater detail, worms and larval stages coming out from infected people, as well as infected livestock, and really throwing the textbook genotyping tools to these stages to see what we can see as hybridizing. So as a very quick close, it's just to show you that maybe with all the different challenges we've seen in recent years, COVID being most important, we should also be looking at the change in the schistosome and also seeing how the environment of Lake Malawi is also changing. The lake is sedimenting, there's been overfishing, there's been some restocking, for example, changes in wash. So I think these hybrids are perhaps a consequence of all of that environmental dynamic. And of course, when we think of how the hybrids will evolve, we're going to be looking at a bit more detail at some of the genetic loci to see what signatures help them raise either morbidity or other change transmission. So that's last from me. I just wanted to invite you to a seminar tomorrow from Cambridge University Press, which is about academic publishing. Maybe Marianne might say something in a second on that. And just to thank my wonderful colleagues in Malawi and also colleagues in the UK, SCI in particular, and colleagues at the museum and colleagues at the LSTM. So thank you very much, Marianne.
Well, a huge thank you to our 4 presenters. I think I can't summarize it much better than Dr. Obiageli Nebe from the Federal Ministry of Health Nigeria, who says congratulations to the Malawian team and partners. Great and interesting presentations, indeed, unpacking a huge amount of issues to be looked at, and of course, eliciting many, many questions and comments from our attendees. Thank you for that comment to Dr. Nebe, and also while I am on the chat with some of our attendees, just to say that we have, again, a great cohort of attendees from around the world. Sam Livernax tuning in with greetings from Cambodia, Fernando Bezerra, hello from Brazil, Rita Nabunji from Uganda, and Julio De Leo, Stanford University, welcome and hello everyone, and James Lecourse from the Liverpool School of Tropical Medicine saying as well, great to see many friends online here, so that really sums it up. We've gone a bit over time, but there just have been so many questions that if any of our speakers can remain online for a few more minutes, perhaps we can attempt to cover 1 or 2 of those issues that have been brought up. And first and foremost, something that's been asked a couple times here throughout the questions, I'll just pick up on Stephen Bramer's question, arthropod pest consultant from Canada, who wanted to ask about the control of the snail vectors. So to what extent has Malawi collaborated with neighboring countries to mount, for example, a regional control of those vectors?
Lazarus, do you want me to start off, or unless you want to go in?
Thank you very much. Can you hear me?
Yeah.
Yes. So far, we have not done much, except the one which Danida, the Danish project, was doing in the previous years. You can recall what Russell was presenting. But at the meantime, we were just in the pipeline to think of working with Tanzania on the Zanzibar project, which have worked much on the vector control. But at the meantime, we don't have much to say that we have worked on the vector. However, if you can remember, what I was complaining in one of the challenges was that most of the funding is that it's tilted towards the interest of the donors. And when you want to divert to other interventions, it's not easy. So the only request which we can make is that if we can have the potential donors to work much on the vector control, I think we can even go beyond what we have been requested for. Thank you.
I think if I can pick up, Marianne, just to say, there are excellent opportunities for using chemical molluscicide control and things like irrigation schemes in parts of Malawi, for example, and we can benefit from Chinese-African collaborations. But the lake itself, being a biodiversity hotspot, you have to be very careful of how you actually manipulate any type of invertebrate fauna along that shoreline. So it's just to point out that there's a little bit of a dynamic between biodiversity and then maintaining that and then trying to control diseases, because you can sometimes have repercussions on fish or other invertebrates in that lake.
Fantastic. Seke, Janelisa, would you like to add anything to this?
Jen? Yes. I think, sorry, go ahead, Jen.
No, I was going to say that I think it is well articulated. There haven't been any non-regional collaboration so far. I think there is need to synchronize OneHealth approach so that organizations and teams that come to work along Lake Malawi are able to talk to one another so that we can see how best we can approach this. So as Russ said, indeed, we also have to be very careful in terms of malacological control along Lake Malawi, because this is something of a national icon, sort of, that we're really proud of the diversity in the lake, and we don't want to introduce something that's gonna upset the ecological system.
Mm.
Sure, and that's very true. I think what everyone has said. In addition, is that the lake basically is. I think there are several pictures which you have along the lake. So there are certain areas where they are free of schistosomiasis. There are certain areas where schistosomiasis is very, very prevalent. So there is need also to identify such kind of spots, because indeed the lake serves as also kind of income for the local community in the areas. So it's a matter of finding out which, so doing a lot more work to actually identify which are the hotspots, and then to see at all whether malacological control interventions can be put in place, those which will not upset the ecology system in those areas.
Thank you for that. Moving on slightly now to male genital schistosomiasis, Seke, your presentation listed lots and lots of questions, and one that came up a couple times, and perhaps this can be broadened actually to just the engagement of communities and what you found has worked beyond that, also for MDAs, but the questions were, how did you convince your participants to be included in your study? What's the magic version?
Well, maybe the first magic was because I'm a man, so it was easier to interact around with fellow men. However, I think one of the key things which even Lazarus said in his presentation is Malawi has a team of what we call local community health workers, which are called health surveillance assistants. So this group of community health workers were a very big help in this study, because these people, these men work in the communities, and then they know the people in their communities, and they know how to approach the people in the community. So I worked with this team, and then they were the ones who were doing the main recruitment of the participants. So they were the ones who were meeting the fishermen, and they knew when the fish, the time when you would find the fishermen. So, for example, for the recruitment, we are doing it either along the lake shore when they were coming from their fishing. Some of them do go back to the lake to mend the fish nets, as well as they also have places of entertainment along the lake. So the local healthcare workers usually would go in these places, talk to the fishermen, and then recruit them into the study. As well as we're also involved, but not very much, because if they see a new person, it was very difficult. And it was also happening at a very peculiar time, because we had a time when there was, in Malawi and in Mozambique, there was a rumor going around that there were vampires around in the area. So we tried as much as possible, those who were not, or those of us who were not, who were new in this area, we left it to the local healthcare workers to do much of the work, and then we would go and see what was happening. And when they came into the hospital, then we would explain all their misconceptions which they had, all their worries. And most of them, they were quite keen to take part in the study, because that, at the first thing is, some of them, it was the first time to get to the health facility and to be investigated for male genital schistosomiasis or problems related to their genital system, which has never happened before. And some of them, it was the first time to have an ultrasound done. So it was quite a plus to them. And at the end of it all, they knew that they would get treatment. And also had encouraged them and promised them that if they had any other ailments, so for example, they had a chest infection, they were coughing, or they were feeling like they have malaria. So we took care of all their health problems which they had. So basically, we were available for them for any other health problems apart from genital schistosomiasis. So that attracted them to come to us. And indeed, they all more or less served as ambassadors, and then went into the community, invited other fishermen. And we noted that at the time when we were doing the 12-month follow-up, we were also seeing new people who were coming in to do the study as well for the first time. So we just asked them, looked at their conditions, did the MGS investigations as well, and told them about their findings, but did not include them in the main cohort because they were just coming in for the first time and were not followed up. So it was a mixture of various ways, having information sheets which explained everything about MGS, using the local structures in the communities, which was very, very helpful, and using the same participants to attract other participants to take part in the study. So this helped a lot in the study itself. And I agree with the people who have put questions. It is really difficult to convince men to do studies involving their sexual matters or involving their genital organs, because basically it's more or less regarded as a taboo or a myth to discuss about this in the public. So it is not that easy, but we are very grateful for the participants who took part in the study. Yeah.
Any final comments from our presenters? There's actually a deluge of questions coming through on the chat, and I think the only way to address these would either be to reschedule another hour and a half just to answer the questions, or perhaps we could email them to you all to answer one by one. I suspect you, of course, all know each other very well, so this is only the start of, or the prolongation of an very ongoing conversation. But perhaps
that would be great if we can get the questions. We can respond to each and every person, so that at least we're able to give all the input which they would want to have. Yeah.
That's very kind of you, Seke, and I see you've been already doing quite a lot of that in the chat already, and Russell as well. Lazarus, Janelisa, would you have any final words to wrap up the session? Perhaps what are you looking as your next steps, or any partnerships, or anything in particular you'd like to see developed?
Lazarus, do you want to go first?
Yes, I can go first. First of all, let me say thank you to the organizers of this meeting, and it has been a very nice one, and I've enjoyed it. What I would like to emphasize that we need more support, not only financial aspect, but even technical support. We need people to come in and even support. Based on the prevalence rates which we are having at the meantime, if we can take the WHO recommendations, we are at the virtue of even upgrading from morbidity control to elimination levels. Now, at elimination levels, there are two challenges. First of all, is that the disease is focal. And the problem which is in one district is not the same problem in another district. So we need now to have an intensive mapping and see where we can manage to eliminate totally and go to other districts where we can still work on morbidity control. So at that aspect, I think we're going to include in the new NTD master plan, which we are developing from 2021 to 2025. And in that new NTD master plan, we would like to highlight a number of activities which will require more support from different donors. I would like to acknowledge the support which SCI Foundation is giving us, and also GIZ, and also WHO, who are the mothers of us all. And I cannot forget my colleagues here, the Janelisa and her team, and also Russell, and so we have got also other colleagues who are working with my program to ensure that we have reached an elimination levels for schistosomiasis. However, the genital schistosomiasis is highly supported to be emphasized in terms of implementation, because we have seen that it's a new area of interest. And in Malawi, we have a program which we conduct screening for we screen women to check their cancer, the cervical cancers, which normally some of the cervical cancer lesions are similar to the schistosomiasis lesions, the genital schistosomiasis lesions. And normally we need to even increase capacity to train the clinicians, nurses, so that they can have the differential diagnosis, so that they can manage to isolate those cases which are suffering from schistosomiasis. So in all those activities, we need support, financially, technically, and even moral support for us to achieve that. So this is what I wanted to request the whole public. Thank you very much.
Thank you very much, Lazarus. That was heard loud and clear. So thank you for those words. Anyone else from our presenters for a final word?
So maybe I can just say just a few words, just wearing my heart as a researcher and an academician. I think we have got a lot of work that we need to do. There's a lot of research that can be done, so we need to network and collaborate. And we have students waiting to do their work. If there's in this group people who'll be interested, we have a number of students available to do a number of research. We just need support, especially financial support. Thanks.
Thank you. And second,
yes, just to say thank you to Marianne and the team, ISNTD, for inviting us to take part in this important talk. And we believe that I think it has generated more interest on genital schisto as well, both female and male genital schistosomiasis, as well as the OneHealth aspect, because I think the issue of schistosome hybrid, I think it's quite interesting as well, because we might, as we have always said, is we have concentrated on treating mass drug administration, but we might have the life cycle continuing in our closed livestock. So that is quite interesting as well. And in addition, there are other waterborne diseases like giardiasis, which are coming in, which could be of interest as well along the lake, as well as along the endemic areas. So thank you for the talk, for inviting us for the talk. And we believe that I think we'll continue collaborating with all our colleagues, even those who are taking part in listening as well, so that at least we're able to bring the burden of neglected tropical disease, as well as just any other infections down in this region, in Malawi, as well as in the sub-Saharan Africa, on this important World Health Day. Thank you.
Thank you. And you've immediately had an offer of partnership here from Innocent Takugang, so who could contribute in further investigations on genital schistosomiasis.
Wonderful.
Russell.
Thanks.
Just to say, I don't want to finish on a kind of like somber note, but I think these conferences are excellent because it raises awareness on a variety of different things. But one of the things which is quite pressing at the moment are the cuts in ODA funding for UK research. And unfortunately, that's going to hit quite a few of the kind of collaborative projects, be it in the OneHealth sphere or in the medical vernacular. So I'd encourage anyone who's got access to those petitions, perhaps Anouk, who's doing a very good job at putting up the web links, perhaps you can make a link to that petition which is going around to try and make the UK government rethink a little about what they should be funding. But I think it's one of the nice things about the research which we have doing. It's always collaborative, it's always supportive. We've got a common goal, which is reducing a disease, but at the same time we have to have sensible strategies to make sure the environments which we live in are also healthy. So maybe that's all I want to say, is we have to try and balance those as well.
Absolutely. And if that petition does reach 100,000 signature, then it must be debated in Parliament and looked at very closely. So if you are a UK resident, by all means, sign it, share it. It's hugely important. Thanks for bringing this up, Russell. So I'm just going to borrow Bonnie Webster's words to finish off the session. Bonnie says, thank you very much to the Liverpool and Malawi teams. Great work. Malawi is a complicated epidemiological environment, lots to do, absolutely. But we got a fantastic flavor of what has been done and what's yet to come from these 4 presentations. So a huge thank you to yourselves for your time today, and a very big thank you to the GSA, the Global Schistosomiasis Alliance, for also bringing all this together. A special thank you to Anouk, who has tirelessly been posting the right link and the right resource. And we do urge everyone to have a look on the chat to review those, whether it be a blog piece or a video recording. Lots of resources there on the GSA website. So that's it for today. A huge thank you to everybody who tuned in. Thanks again to our presenters. And at ISNTD Connect, we will be back next week, and we'll be looking at supply chains and how supply chains are evolving to support NTD control. So until then, I wish everyone to have a good week, keep safe, and I hope we get to meet in person again very soon to answer all those burning questions that have remained unanswered for today. So thanks again, everyone, and we'll see you very soon.